So ridiculous it is, that is the title. And that's what we're going to do. And I do sometimes talk to medical students about giving talks and give them all the guidance that one slide a minute is probably more than you'll ever get through, and I have 120. So we're going to be, so this, if you were here last year, I gave this talk. I thought I'd never get asked again, and I swore I would never do it. And I think either I was drunk or something, but the invitation came through, and I said yes. So I did lock myself in my room last week, and this is the same talk again. So I suspect this will be the last time I'll be asked. Anyway, we are going to get through it all, and the idea is that you do get a good overview. So again, disclosures. I'm going to be talking about lots of drugs from lots of companies, and I have done bits of work with lots of them. I hope that without fear or favor comes through. Right, so what we're going to do, at the end of this 40 minutes, those of you that are still awake, will hopefully have developed an overview of what's going on in terms of ongoing and up clinical trials in MS. There is a focus on disease modification, so clearly there's lots of things like rehab, etc., which I'm not going to have time to do or attempt to do. So I showed this slide last year that my great fear of this talk is it'll be about as exciting as the shipping forecast, okay, and that you will sit there and gradually be lulled to sleep. While trying to update the talk, I found this, which on YouTube there is a 5-hour podcast you can get of just back-to-back shipping forecasts, which is on an insomnia website. So you can actually just sit and listen to the shipping forecast for 5 hours, which is anyway. Right, so what did I do for this? Clearly, to try and be a bit systematic, I've gone to clinicaltrials.gov. Now, I mentioned this website last year. It is critical that this website exists, okay? And I know there's some pharma people here. Evil pharma companies, okay? Clearly, if you would like to do something, you would do 2 trials. If one was positive, you would publish it. If one was negative, you would bury it, okay? So wise to this, the world has said that if you're going to do a clinical trial in people, that trial must be registered in advance of it being done so that people can track down the negative trials and make sure that all the information is out there. So clinical trials exist. It's a great resource if you want to see what's happening out there. So I went on last Saturday. Again, you'll see my slight tendency to procrastination, and went on it. And if you type in multiple sclerosis and look for trials which are active and recruiting or not yet recruiting, there are 563, okay? I'm not going to present all 563 of them. Most of them. So I've kind of focused in really on, I've got rid of things that probably aren't that interesting to us, so simple registry studies I haven't done, extension studies that you know about, I've included a few, really small studies I haven't got through, things that didn't interest me I've left out. So it's a slightly curated view of this, okay? There's no particular strategy. I hope that basically every big study is going to be in here and all the ones that are likely to come across your desk in the next couple of years, but I've had to prune a little bit. Right, you ready? Here we go. Okay, so radiologically isolated syndrome. Clearly getting into the world of MS nurses now, patients get very anxious when they're found that their scans may show MS and they have it in symptoms. I refer a lot of them to RMS nurses so that they have someone to run symptoms past, okay? So, you know, when they get that tingle, someone can tell them, no, that's not it, and send them away. So it's been very hard to know what to do. The great and the good, when the McDonald criteria came through, have decided that we're not going to call it MS, even if the scan is changing, even if they have enhancing lesions, if they have oligoclonal bands, it's still not MS, and the best advice is that you still don't treat. But clearly it's a bit of a grey area, so there are trials going on. Teriflunomide is doing a trial in radiologically isolated syndrome, and dimethyl fumarate is doing a trial in radiologically isolated syndrome. They're going to report the next couple of years, and they're going to tell you whether treating these people with this averts a first clinical event or whether it's a waste of time. On a left field, okay, and I've put in a few of the quirky ones. This is not a small study. This is 100 patients, an Italian study, giving them a BCG vaccine. Now, I have no idea why you would do that, okay? It's to stimulate their immune system and try and do it, but it's being done. Their justification for doing it is that it is safe, cheap, and handy, okay? I don't know whether that's a translation error. There are many things safe, cheap, and handy you could do to people with RIS. They've chosen this one, and that will report in a couple of years. So, pediatrics has been a big evidence-free area for us. You'll know that fingolimod has done a trial against Avonex, which has shown its superiority, marked superiority Avonex. Despite that, it still is a second-line license, and you have to put a child through injections with Avonex, and they have to fail before they can go on fingolimod, despite the trial advice. But we have some other studies, everyone jumping onto this. So, who else is jumping onto the kiddie bandwagon? Teriflunomide has got a placebo-controlled trial up and going, again, presenting 21. This has been slow to recruit as against placebo, and bearing in mind that we can treat children off license, it's kind of hard to recruit a child to a placebo-controlled trial, but that one is up and going. There's a dimethyl fumarate study called CONNECT, which is DMF against Avonex, and again, it's got a couple of years left to go. A new one then has been this top one that you see here, which is Plegridy, dimethyl fumarate, and placebo. Now, I think the reason for this one has been, the FDA are very odd about if you try and do a comparative study to a drug which hasn't already been proven to work. Okay, so if you show that, for example, in this one, that dimethyl fumarate is better than Avonex, that's all well and interesting, but if you don't know that Avonex does anything, what do you know with that result? And if you show that DMF is as good as Avonex, is it possible that neither of them work? So you will see now, there's been added to this a study with the placebo arm with dimethyl fumarate and Plegridy, a 2-year study opened just last year and is up and running. And then Plegridy, there's then an open label long run on Plegridy going on. Again, this isn't placebo controlled, but clearly is going to supplement the exposure data to the previous study. Alemtuzumab, LEM-KIDS study, not particularly innovative, TerryKids and LEM-KIDS, is out there. This is a small study. It's only for patients that have failed previous treatments. It is one kind of open label, okay, so there's no placebo group here, and trying to get safety data to see whether it works. This has been suspended with the license, but I think is planning to get up and going again for under 18s. Okay, ocrelizumab, not surprisingly, getting in the game as well. Very, very tiny study planned, okay? And basically, if you look at it, it's pharmacokinetic. So it's really just trying to work out what dose would you give to children, and that would turn out to be roughly the same as the adult dose in terms of how much ocrelizumab gets into the system and how much it depletes the B cells. So I don't know whether there's plans to do an efficacy study, or if they're just going to carry over, well, this is the dose that gets you what you get in adults, so this is the dose you would give to kids. So that is out there. This is a weird one, okay, which is giving metformin to children who have had MS and optic neuritis. You'll know metformin is a drug we use for diabetes, but in some of the high throughput screening ones, there's a suggestion that it may be a neuroprotective drug. So these are kids who've had MS, had an optic neuritis, they're putting them on metformin, and they're looking to see how well their eyes work at the end of a year. So that's kind of a little bit interesting. Okay, and just in this kiddie section then, a pregnancy study. I've kind of not done a lot of pregnancy studies, but this is an interesting one. So this is women who haven't been on treatment through pregnancy, just starting them on natalizumab. Immediately they deliver to see if you can get them through that at-risk period for the first 3 months. Probably a little bit out of date now, bearing in mind we're tending to treat women through pregnancy, but it is up and going, and interesting that people are at least catching it. So that's kids and women. Relapsing remitting MS. Okay, women and children first, and then moving on. Okay, right, so these are new agents. I thought it was funny. Okay, right, so these are new ways of treating MS as opposed to old ways reheated. So this is a new group of drugs, okay, the tyrosine kinase inhibitors, okay, and because they are tyrosine kinase inhibitors, they are all NIBs. An inhibitor. Okay, so and there are numerous tyrosine kinases that you have in your body. They tend to be quite cell specific. So if you have a molecule which inhibits one specific tyrosine kinase, it will knock out that particular cell. So Bruton's tyrosine kinase is found in B cells. It plays a key role in their development. So if you have a drug which targets Bruton's tyrosine kinase inhibitor, you are then going to have a drug which is going to target B cells. This is going to work a little bit like ocrelizumab. So this one's quite far through. So evobrutinib, we've seen a positive phase 2 trial, and there are 2 matched massive phase 3 trials going. So these are conventional phase 3 trials, and they are going against Avonex. Okay, they're set to complete in a couple of years' time. The dose, we don't quite know on the website. They say it's a BD dose. 75 BD was used in the phase 2, but actually only 75 once a day was statistically significant. So I don't know whether they have gone BD or not. There's a little bit of difference between the way these results were reported first and then the final publication when the stats were redone. But I'm guessing it's maybe 75 BD, and that is up and going. There's a drug very like this that Sanofi have, okay? Another Britain's tyrosine kinase inhibitor, another BTK drug. Phase 2 is done, okay? We don't have the results yet, but I think it's close to completion, if not completed. There is an extension of the phase 2 running out to 2025, but the phase 3 program is in development. And I think without having to sign a confidentiality agreement, I was asked to do a relapsing remitting study, a primary progressive study, and a non-relapsing secondary progressive study. So this is being looked widely to see. So one can guess that the phase 2 must look relatively encouraging. Right, another strange drug then. Okay, so this is apparently running from the Queen Mary in London, although I reported it last year, and this year it's put down as not yet recruiting. So I don't know if there's anyone from Queen Mary here. So this is another one of these fancy new drugs, and this is a zomib. So zomibs inhibit proteasomes, so they're proteasome inhibitors, okay, which gives you zomibs, okay, and ixazomib targets plasma cells. Now, we've never deliberately targeted plasma cells in MS, but we have an NMO. And if you know the 3 new super expensive drugs coming out for NMO, one is an antibody against plasma cells. So this is a small molecule which is going to hit plasma cells. It's given a rather odd way where you give it 1 week for 3 weeks and then you get 1 week off. So this has been studied. Phase 1 trial, I don't know what's happening with it. It's still listed as going. And the primary outcome, interestingly, is to see whether you can turn people oligoclonal band negative. Okay, because obviously plasma cells make the antibodies. So if you're killing the plasma cells, you should turn the antibodies off. So that's actually the first thing they're looking at before they look at whether it works. Right. Also still listed as this weird Eastern European one, okay, looking at a strange combination of peptides, metenkephalin and tridecatide. I don't know why that has come together. It's probably someone made it in their bedroom, okay. It is still listed. This is no small study. This is a 400-patient study, so this is a big endeavor. It was meant to be completing in 2022, but is also down as not yet recruiting, so you may want to hold off buying your shares in Bosnalejek just yet. Okay, right, a few weird ones then, okay, so this is a drug, it's not a new drug, but it's new for us in MS, which is targeting the IL-1 pathway. So IL-1 is one of those real key rocks of your immune system. It's already targeted in rheumatoid arthritis with this drug anakinra, some of you may have heard of. Okay, so this is a slightly odd one. You know that MS lesions, they appear, and then some of them become chronically active and just spread out at the edges. And in that edge, there's a lot of iron, and you get this paramagnetic rim that you can see on 7 Tesla MR. So this is a study using an anti-IL-1 to see whether we can get rid of those slowly spreading lesions. So a new target for MS, which is targeting one of the pathologies of progressive disease with a specific drug. That's kind of interesting, okay? IL-2 has an interesting run in MS. As you know, IL-2 was the pathway targeted by daclizumab that blocked the IL-2 receptor. Okay, so you might think it's brave for people to go back in there again. Okay, but what they're actually doing this time is instead of trying to block IL-2, they are giving low-dose IL-2. And low-dose interleukin-2 seems to boost your Tregs. So this is a small study, okay? It is publicly funded by France. I shall not attempt to say that for you. There's nothing as funny as French in a Belfast accent, okay? So they're trying to see first whether it works and then to see whether it actually will give you more Treg cells and then whether there's a clinical effect of that. So that's the new targets, okay? So you can see there's kind of stuff happening there, moving away from traditional immune kind of places we've been. So relapses. So what are we doing for relapses? This is a fun one because we had Dr. Olsen here last year. Okay, we presented this, and this is his study. So we're looking at imatinib. So this is another one of these tyrosine kinase inhibitors. This one is found in myeloid cells and lymphatic cells. It's already used in cancer, and they are looking to see whether this is better than steroids for relapses. So again, this is likely to report this year. That would be kind of fun. So it would be if patients came in with a relapse, perhaps instead of giving them steroids, we would give them imatinib for 2 weeks. weeks, okay? One suspects imatinib will be more expensive than methylprednisolone, okay? But I suppose if it did a whole stack better in the functional outcomes at 1 month and 12 weeks, you might think it's worth it. It's interesting because my practice would change if I had a dangerous drug for relapse. I think most of us think, might be relapse, might not a lot to go wrong with steroids. What if suddenly it was a really expensive and dangerous drug and you actually had to tell the patient that you didn't believe it was a relapse? So anyway, enough said. Right, what else is happening for relapses? Isoxsuprine, okay, which is a drug most commonly used for hoof disease in horses, okay? Also used as a smooth muscle relaxant to delay premature labor, okay? But it has also been shown, again, one of these weird drugs when they'd screen lots of drugs, that in a small study it appeared to reduce disability in animal models of MS. Okay, so again, it's going to be used as a relapse one. Their study is using it in adjunction to steroids, so you get your steroids anyway, and then you do get your isoxsuprine or not afterwards. Lovely hair and nails after it. Who knows what it does to your MS. Okay, I mentioned this product last year as well, which is ACTH, which was the first clinical trial ever done in MS, was a randomized trial of ACTH versus nothing. See, Karen, no, it was a long time ago, dear, but were you there? Yeah, those of us who are very old will remember patients getting ACTH injections. The whole thing with ACTH is piss cheap, and therefore, as you can guess, no one's going to do a trial on that unless you formulate it into a cream, okay? And then a bit like creme de mar. See, my wife tells me these things. You can now get creme de ACTH, okay, which put the price up 10,000 times. Okay, so this has been a fun one. Okay, as you can guess, having done this, they're rapidly trying to find out where it works. So it appears several times in this talk. One is to see whether, if you failed response to methylpred, if you rubbed on the magic cream afterwards, might you see an effect afterwards? And that one is up and going. Right. Back to the lookalikes. So the first section on relapsing remitting disease with the new agents, these are new targets. These are drugs that look like drugs we already have, okay? And they're kind of expanding, but maybe not such big news. So the first one is this emphasis trial, okay? So this is looking at a new teriflunomide-like drug. It's called vidofludimus, and I so hope that this trial works, because the thought of putting someone on vidofludimus just would just make my life forever, okay? So it's going through, it's at phase 2, okay, and it's looking to see what it does to MR as a first run. Okay, there is a German company, no, a Russian company called BioCAD. Okay, I will say nothing bad about them because they are listening. We love you. They are apparently a major Russian biotech company, okay, and they appear twice in this. They are making a pegylated interferon, okay, so a kind of Plegridy-like drug. They're trying it against Avanex, and it's actually due to report this year, okay. I suspect the patent lawyers are out there. What else do we have? Ponesimod looks a little bit like fingolimod. As you know, ponesimod has already reported its phase 3 trial. The Optimum trial was reported at ECTRIMS. It works in a fingolimod-like way. Okay, and it seems that the magnitude of the efficacy is much the same as fingolimod. It may be easier to start without a first dose effect, and it was an interesting study because they had fatigue as one of the main outcomes, which is quite nice. It's the first time we've really seen a patient-related outcome measure put up there on a level with the radiology and relapses, which is nice to see. Okay, but they've done this weird one as well of adding it to Tecfidera, okay, so an add-on, and combination therapies have not been hip in MS for a long time, whereas here we have a drug coming along, you're failing on your DMF, and instead of switching to another drug, you put another drug in on top of it. So that's due to report this year, and there is a long-term extension of the Optimum trial going as well. This is an interesting can of worms, okay, which is the new fumarates coming out. So diroximel fumarate, okay, is a drug which is, when you take it, instantly becomes monomethyl fumarate, or MMF, okay, and as you may or may not know, dimethyl fumarate is also a drug that the minute you take it becomes MMF. So dimethyl fumarate is essentially a prodrug, and diroximel fumarate is a prodrug. They're both turned into the drug, which is monomethyl fumarate, and by an interesting twist of fate, the FDA have decided the drug is MMF, not DMF. So anything that turns into MMF when you eat it can use all dimethyl fumarate's data for efficacy. So this is a diroximel fumarate, is a pro-MMF drug. Okay, it has got a single trial going, which is open label. okay, which is going to run for 96 weeks. So everyone is getting diroxyl fumarate, okay? Interim results show the annualized relapse rate is 0.16, which is maybe what you might expect on DMF. You're going to have to guess here, but the primary outcome is adverse events. There is one head-to-head, okay, which lasted 5 weeks, where diroxyl fumarate went against Tecfidera, and the primary outcome measure was GI events. This seems to be better tolerated than Tecfidera, so the adverse events of discontinuation were 1.6 versus 6. On the basis of these two studies, this drug is approved. Okay, and in the States is Vumerity. Okay, so watch this space for the new. Sorry? Yeah, it's nice, isn't it? Kind of, yes, it sounds like a virtue, doesn't it? Yeah, chastity, fraternité, égalité, vumerité. So it is there. So watch this space. Okay, interestingly, it is owned by Biogen. Okay, so maybe why there's been less noise about it. However, the vultures are circling around dimethyl fumarate. A company called Banner Life Sciences have a monomethyl fumarate, slow release, which is apparently got a trial going. And again, on the basis of existing and promising to do a 5-week trial, this drug has tentative FDA approval from January of this year. So anything that you can make into MMF will be around. So we may see more fumarates coming on the market. So what else is coming out there? There's a biosimilar to latalizumab called PB006. I'm not sure whether Antelope is the trial or the name of the drug, but that is out and being tried. And then there are a whole stack of B-cell lookalikes out there, okay? So these are ocrelizumab-like drugs which are circling and coming to a clinic near you. First off, and I put it in, it probably doesn't really belong here, but it's still listed, ofatumumab is clearly completed its 2 phase 2 trials. It is subcutaneous form of anti-CD20. It looks very like ocrelizumab in terms of the results, but is given by self-administered subcutaneous injection by the patient. There's an extension cohort, and there's a Japanese cohort going on. There's a drug called ublutuximab from a company called Ubladi. Has anyone seen yesterday? Great film. Okay, so this is ublutuximab, Ubladi, Ublada, life goes on, as does ublutuximab. It's going up. It's, again, nice running, 2 paired trials set to come out in 2021. It is a kind of ultra-humanized form of anti-CD20, but will be working roughly the same way. The nice Russians, hello again. So they have their one called BCD132, again an anti-CD20, but an oral one. No, it's an IV one. Okay, and then the phase 1 of that is going on. So lots of CD20s coming out. So the head-to-heads then, so this is where the Swedes really come in. So lots of cheeky Swedish studies in rituximab, okay? As you know, and for anyone listening, not licensed for use in the UK, for use in MS, but widely used elsewhere. So they are doing rituximab versus dimethyl fumarate, okay? So clearly one of the arguments has been we can't use rituximab because we don't have RCTs, we only have real-world stuff. We are going to have to deal with the fact that there will be RCT data out there showing how well this drug works and lots of evidence and safety to work out what we're going to do with it. So this one is out, and again, estimated to repeat in 2021. The Italians, cheekily, are doing fingolimod versus dimethyl fumarate. Again, is meant to complete this year. The Norwegians are looking at cladribine versus rituximab, okay, which is an interesting little one, the NOR-MS study. Again, randomized controlled trial. Again, should report in a couple of years telling you whether rituximab is as good as cladribine. It's a non-inferiority study looking to see if they have similar results. Again, the Swedes are at it. They love the rituximab. Okay, Combat MS is rituximab versus all other drugs. Okay, so it's a real-world study. It's not randomized. Nearly 4,000 patients. They're collecting data prospectively and retrospectively, MS severity scale and disability progression, and that is versus all drugs to see if rituximab has its place. So that's all coming out there. Stem cells. Okay, so AHSCT, we all think it works. We have some trial from the MIST study suggesting it does. Ongoing, we have stem cells versus alemtuzumab, which is happening in Sweden. We have stem cells versus best of the rest, okay, which is the BEAT study, okay? And then we have this guy, Bert, who's doing the MOST study. So he doesn't need convinced that stem cells work. All he's looking at is the conditioning regimen to see which of them works better. However, this is the one scan, if you like, of the scandal, okay, is that his clinic has just been shut down. It's kind of fun. FDA, we're not allowed to say, gossip is good, okay? He has, however, his entire clinic program and all his trials have been shut down because he wanted a sabbatical to write a book. Oscar Wilde and Jeffrey Archer both took sabbaticals to write books as well, but we'll see what happens with that one. Right, primary progressive MS. So what's happening out there? Again, the magic gel, okay? Would it work? Rub it on 3 days a month to see whether it's worked. That one's going. Ocrevus in upper limb function, again, ocrelizumab. So this is a small study I've chosen because it's the one that listed, but we know that the bigger OHAN study is out there as well, looking at patients with advanced MS to see if we can keep their cognition and upper limb function together with B-cell therapies. So again, that is out there. Couple of small molecules, hydroxychloroquine, again, used in rheumatoid arthritis. Investigator-led study due to complete this year. Dimethyl fumarate in primary progressive disease. You may or may not know the company had planned to do this study and then pulled it, but there is a small study that has been done in Denmark which is meant to have completed. It's still listed, so it'll be interesting to see whether there's any promise there. This is a study looking again at a kind of a little bit, I think, like MS SMART. So pioglitazone, montelukast, losartan, hydroxychloroquine, 4 repurposed drugs in primary progressive disease. And really what they're looking for here is looking at the drugs in combination is, can we predict response? And there's a lot of work being done in this study to find out can we try to profile patients towards a responder or not. Masitinib, again, another one of these NIBs, okay, tyrosine kinase. This time, it's going to get your mast cells. Now, this is a cell group that you really wouldn't have thought of targeting in MS. These are the ones that give you histamine reactions, asthma, allergies, but we've got a drug that's going to knock these out, and it's being tried in primary progressive disease. Biotin, that you'll know is up and going, and the kind of double-blinded phase of that is over, and we should see results this year, and the open-label extension is on. So a lot of studies for progressive disease are now combining into progressive disease. As you'll know, the American licensing no longer recognizes a lot of the phenotypes that we had, but there are some where secondary progressive disease is still out there. So domperidone is being tried, okay, anti-sickness drug. If any of you do Parkinson's disease, you'll know this is very good for sickness in that. It's a dopamine blocker. It increases your prolactin, and prolactin is thought to be potentially myelin repairing. So that one is out there, kind of fun. Okay, this is just to remind you that siponimod is out there. It is now licensed in the States. It's nearly licensed in Europe. Novartis are doing a helpful study for us to see whether you can switch people from their current therapy to siponimod safely. So this is the exchange study. Okay. Simvastatin in secondary progressive disease, Jeremy Chataway's group. So this is a small study looking at how simvastatin works. So we know that from the phase 2 that simvastatin seems to slow progression in MS, but it's not quite clear whether it's necessarily tackling the MS or maybe just keeping the non-MS part of your brain healthy. Okay, because clearly losing either bit is going to make you disabled. So this is looking to see what simvastatin does to your cerebral blood flow. Okay, and then obviously we have the Big Daddy study, MS-STAT, looking at nearly 1,200 patients, phase 3, estimated to complete in 2023 if it recruits, and that's a little slow at the minute. And I'm partly at fault for that. However, we're going to get your fault as well. We're all going to do better this year for MS-STAT too. We are. That's my pledge. Right. So, old dogs, new tricks. Okay, so this is really maybe not so much breaking boundaries, but looking to see can we use what we currently use better. This is kind of an interesting section to me. So the NOVA study we've heard several times already. Can we spread natalizumab out? The study's going to go to 6 weeks, okay, and see whether we get the same efficacy that we get at 4 weeks. So rather than kind of just reports of people who've chosen or centers that have chosen, this is randomizing patients to stay on 4 weeks or to go on 6 weeks and see what the MRIs look at the time. I think this will be game-changing because this is not just looking at how you give it for positive people to reduce the risk. This would take everyone from 13 to 8 infusions a year with the drug at the same price. So if this is potentially just going to change how we give this drug, full stop. So I think that's a fun one. Okay. Ocrelizumab, Ensemble Plus, not the world's most exciting study, but one of the things with ocrelizumab is, you know, it takes 4 hours to give, so it's quite a long sit for the patients. Could you do it in 2? Okay, so that's what that study's looking at. Ocrelizumab, could it be given subcutaneously? Okay, not saying anything, but you know, if you have a drug that's IV, and I've told you that ofatumumab's coming out given by subcutaneous injection at home, is it possible ocrelizumab could be given by subcutaneous injection? So a crowd called Roche are looking at this to see whether that is the case. Okay, this is a fascinating one. Okay, so we have ocrelizumab. When we talk about the safety profile, one of the worries is the long-term loss of immunoglobulins. Okay, there is always been a little bit of a notion that it might be an immune resetting drug. Okay, you rapidly wipe out a lot of B cells. A lot of the B cells you wipe out will be the ones with the MS. The ones that grow back are new. So it is possible that ocrelizumab might be an immune reconstituting therapy, and that you don't need to keep plowing on with it every 6 months. Okay, so Johns Hopkins are doing this. You get 2 rounds of ocrelizumab when they're stopping, and then going to see whether the disease comes back. So it's a small study, but I think very much one to look out for as we try to give this highly effective therapy more safely. Okay, I do love this. The investigators hypothesize the disease will not come back. Okay, again, just in terms of how we give these B-cell therapies and are we overdosing them, again, those pesky Swedes with their rituximab. So rituximab full dose is 2 grams every 6 months, okay? And they are looking at seeing they can get down to 500 milligrams 12 monthly, okay? That's an 1/8 of it. So that would be, for us with ocrelizumab, could be given 1/8 of our current dose of it and still get away with it. So again, that's maybe one to look at. Okay, and then glutarimer acetate, 1 monthly depot form of it is being tried by a Chinese company, I think they are, called MAPI, and they're looking at that in relapsing remitting disease and primary progressive. So, starting strategies, okay? We all know that there's a little bit of a debate. Do you start low and go high? And we all have our own feelings on it, okay? But some people are trying to do trials. We have Deliver MS, which is Nikos's trial. Was Nikos at this meeting? Okay, no, never mind. Okay, great study. And we didn't sign up for it. Okay, but basically what it is that you get randomized either to slow and escalate, or you get randomized to high trial, or of course the worry is that you get randomized to the group and then you don't like that group once you hear about it, okay, and you can duck out and go on to an open label extension. But potentially by 2023 it will tell us in a randomized way. As you know, MS Basis tried to answer this question by propensity weighting and looking at the data, and they suggest it is better to start high, but there's always worries that you can't control for everything. So this is a good, pure attempt to try and do it as a controlled study, and a very similar one coming from Johns Hopkins called Treat MS. How safe is switching, and can we do it? Okay, it is very nice to see the drug companies do this research, and they are all finding ways of you coming off natalizumab. Okay, so we do have one investigator-led one of natalizumab teriflunomide. Genentech are very nicely helping Providence Healthcare get you from natalizumab to ocrelizumab. Genzyme are very nicely helping you get it from natalizumab to alemtuzumab, and EMD Serono, which is Merck, are very happily showing you that you can go from natalizumab to cladribine. So there are a number of studies showing how to switch off natalizumab mechanisms, and is it safe and is it effective. Stopping, okay? We're all very good at starting MS drugs, but we don't quite know whether we can stop them and it's safe. The minute you stop it stopping, people will all tell you their horror stories of someone that stopped and had massive rebound. However, a lot of people do stop the drugs and get away with it. So we have a French study looking to see if people are over 50, have been on disease-modifying therapy for 3 years, and have been stable with no activity, can you stop the drug? And clearly, some people will stop and stay well, some people will relapse, some people get MR activity, but this will help us see who actually, what are the risk factors for going off. And a very similar study, discontinuing drugs, and this is the American one, the DISCO MS study, which is, again, one of my favorite trial names. Okay, right. Okay, how long have we got? 5 minutes, okay? Right, in 5 minutes, we're gonna have to be selective what we'll go for. We'll go for remyelination, okay? And then we'll go to the funnies. Okay, right, so remyelination, clearly one of the big goals that we have. So if you can't treat the disease or stop it, can we make people better? Opocinemab, okay, so this is the affinity study. You know the people with MS have lots of progenitor cells, but to get in there, they get blocked, okay? So there's a molecule pairing called NOGO and LINGO that block the cells getting in. So this is an anti-LINGO, and it seems to help the regenerating cells get in. That's being added on to your existing therapy. The head-to-head bit of the phase 2 is nearly over, and people are going into open label, so that will be interesting. Okay, we have a small molecule, which I think does much the same thing, again, coming from Biogen, looking to see whether we can do neuroprotection in people with relapsing remitting MS. Nanocrystalline gold. taken orally, okay, which is what you might think from the prices of some of our drugs, okay, and this is genuine gold giving it to people, okay, to see whether it is neuroprotective. And again, there's a study going on optic neuritis and a study going on, again, with people with progressive disease to see whether proof of concept if that's how it works. There is a new monoclonal antibody called elezanumab, okay? And again, this is one, we know that you could regenerate, and repulsive guidance molecule A is one of these things that if you can block, it seems to let cells get in, promotes axon regeneration, phase 2 study up and going, reasonable numbers, okay? And again, hopefully finishing this year. So these are add-ons, so these aren't going to substitute what you do with the immune system. These are going to be stopping the immune attack and protecting the brain or promoting repair. 2 hormonal therapies, okay? So in a high throughput screening one, it seemed that this estrogen receptor modulator may promote remyelination, okay? So a study for women only, okay? And it's going to see whether it comes through. However, for men, testosterone is also being tried, okay? So either blocking estrogen or giving testosterone may be potential things which are going to be good, okay? Now, I'm going to whiz through for the sake of protection, okay? Okay, good. I'm going to, let's go through, I'm just going to go through cell-based therapies. I'm going to leave these out, okay? They are interesting, but we'll leave them out and put them in next year, or another time, okay?
Come back next year, Marty.
Vitamin D and diet, okay? Vitamin D, okay? You'll know the evidence for vitamin D is weak once people have MS, okay, in terms of preventing relapse or preventing progression, but might it stop your first attack after a clinically isolated syndrome? So this one has been running in France for a while and will report. I think might be quite interesting. Ketogenic diet, okay? Again, if you work side to side with epilepsy nurses, you'll know that this is a big thing. Might there be a metabolic element to MS that we can treat? So that is being looked at as well. Lipoic acid, okay? Again, in terms of dietary supplements, a lot of our patients buy this over the internet. We sometimes see it's kind of one of those trendy ones out there. They're on their ALA. So at least it is being looked at properly, and we'll get a trial on that. And again, N-acetylcysteine, the antioxidant that you use for paracetamol overdose. Okay, again, that can be taken by tablet, and that's being looked at as well. Gut, okay, I'm going to show you one gut one because it makes me laugh, just because I read it wrong. Okay, so there, as you know, that we think the gut microbiome plays a large part in your immune system. So this crowd are replacing your gut bacteria with someone else's by colonoscopy. This crowd are doing it by PO capsule. I read poo capsule, and it made me laugh. Okay, but it's actually per orally. Okay, right. We shall finish then in 30 seconds with what I thought were the best studies out there, okay? A really weird one, intranasal insulin. Who would have thought, okay? So an insulin spray up your nose to make you cleverer, okay? And that is being done. 24-week study. I think it's going to repeat this year. And there are animal studies that show that it might be effect. That would be fun. Okay, photobiomodulation. This is shining lasers on people, okay? And this is actually a listed study, and you either get it sung under your tongue, over your spinal cord, or over your radial artery, okay? And that's to see whether you can improve your EDSS by shining a laser on you. I have no doubt that study will work. I love this one. Open-label placebos for fatigue and MS. Non-deceptive open-label fatigue placebo. So you will go into a trial where you're told, I am going to give you a dummy sugar pill that has no biological effect whatsoever, and I am going to measure your fatigue score at the end. And there is pilot data to show they work. So if you tell someone, I'm giving you a tablet that does absolutely nothing, and then my absolute favorite, anyone from Sheffield here? There's a trial of cycling shorts in MS. To see whether it improves walking. And the primary outcome is adherence, the percentage of time actually requested that is worn. And I've spent time doing this. Oh, look at that. Wait for the end. Wait for the end.